Hi, good morning, everyone. I hope that everyone can hear me and see me. My name is Mina Niknazemi. I'm an OccluSense consultant here at Bausch. If you have any difficulties hearing or seeing me, I'm going to try to keep the meeting chat in one eye and keep the presentation in the other one. So please feel free to drop me a message in the chat or turn on your mic to let me know if you have any difficulties with the technicalities of this presentation today. And if not, then I'm going to get started. If you have any
I'm
questions, hi.
I am not able to log in. I'm Dr. Narayana. My password says incorrect when I'm signing in.
Okay, but you're in the chat, right? You're in the presentation, so don't
Oh, all
worry.
right.
Yeah.
Okay. Right.
You can
Thank you.
see my screen and you can hear me?
I'm able to hear you.
Perfect. Can you
Thank
also
you.
see my screen?
Yeah. I'm not able to see the screen. That's the point.
Okay. Maybe try logging out and logging in again using the login information in the email.
Okay.
Can everyone else see my screen?
Yes.
Perfect. Okay. All right. I'm going to give it another 10 seconds for the logging in and out. And if not, then the beginning is just introductory. So I guess we can get started. There's not much to be missed. Yeah, so good morning from Germany. I believe we have visitors or listeners from all over the world today. So whatever time it is around the globe, I hope you are enjoying the Saturday. My name is Mina, and I'm very happy to present the OccluSense from Bausch to you today. So the company Bausch, which was established back in 1953, all their life. And my presentation is going a bit too fast. I'm so sorry. Let's try this again. There we go. So Bausch has been working on occlusion ever since 1953. And if we think about what occlusion means, it's basically the contact between the upper and the lower jaw. So any restorations, for example, fillings or a crown that's too high, too low, they mean an intervention in this system, and they must be monitored and adjusted by the dentist accordingly. And Dr. Hans Bausch, who was a dentist himself, he developed the articulating paper back in 1953 with the progressive color transfer because he was aware of the importance of the masticatory forces and their effect on the occlusion. What you can see here in this video is a production site in Germany. So we are based in Cologne. I'm based in Cologne. And we also have a second production site in the Eifel. It's about an hour away from here. OccluSense by Bausch, a different way to look at occlusion. This is a very straightforward question to ask, which I already answered in the first couple of sentences that I presented to you today. But I bet you any money if I were to ask two different professionals only, everyone would give me a different answer with a focus on a different aspect. And this is why I just want to touch up on some basics briefly. Let's take a very short moment to visualize the main aspects during static and during dynamic occlusion, and then think about how we actually test this on our patients. The current standard involves articulating paper with different shapes, such as pre-cut strips. They can cover the full arch, or they can be rolled and ready to cut into pieces. And obviously the different colors, which may vary in thickness, with the standard shim stock foil, for example, being 8 microns thin. And to check occlusion in all dimensions, what we primarily do is use different colors. So in this diagram or video, you can see red being used for static, black for protrusion, and green and blue for lateral protrusion and medial protrusion markings. I don't have to tell you that this is a very, very time-consuming manner for every dental professional, especially if this has to be repeated a few times. And that's where OccluSense comes into play. So we have occlusion in a digitalized manner. And as you can see here, you have a wireless handheld. We use an electronic pressure sensor to sense the pressure changes. And this can be placed into your patient's mouth, and all movements can be recorded accordingly. As you can see, there's pins and holes in the sensor, which are asymmetrically on the sensor. So the only way to put this in your handheld is the correct way, and the correct way is up. Once this is done, when you've inserted the sensor into your patient's mouth, all the information will be transferred wirelessly, and the markings will be put in your patient's mouth within this one session. And as you can see here, that's the visualization that the OccluSense app will then show you on your iPad. You can do this for static occlusion as well as dynamic occlusion. So any movement that you want, you can have recorded and commented on your iPad. I'm just going to take you very briefly through how this works and what your OccluSense system consists of. So you have this handheld. You need an iPad with the OccluSense iPad app, and this app is available to be downloaded free on the App Store. Any updates are also free. And you need sensors. So the sensors are available in two sizes. We have X and XL, and they differ in width rather than length. So they're very, very highly sensitive. That means that they can capture up to 256 different pressure levels, whilst they still remain only 60 microns thin, and give you still very good flexibility, so they're easy to use on your patient, and they can be easily inserted into the patient's mouth. And one very key factor for me, the red color coding. So this method of occlusion control, it still leaves the mark inside the patient's mouth, just like your standard occlusion paper. To get started, you need to initially set the system up. I'm going to briefly take you through what you're going to have to do for this. So first of all, you need to ensure that your iPad is connected to Wi-Fi. Once you've done that, you can go onto the OccluSense app and start your initial setup. And then you will be guided through every necessary step. So nothing you need to really remember, take notes on, because it's literally just pressing the buttons and going next, next, putting some details in and so on. And once you've done that, you're ready to register the system. And if you're as tired of hearing my voice as I am, I mean, we still have a few minutes left, but I have a little video for you as well, so we can switch it up a little bit. And that's it. Your system is registered.
Functionality test handheld. You will now be asked to insert the test sensor correctly and close the sensor flap. Function test starts now. The result of the function test is displayed in the app. Now, test sensor from a handheld and put it back in the storage box.
So this video that you've just seen, I've put in there just so you are able to see the sensor test. So what you will receive with the OccluSense system, I'm sorry, I'm trying to put my light on as well at the same time because I see that I have a big fat shadow on one side of my face, which is not very necessary. Okay, maybe this helps. Ah, a little bit. All right, never mind. Didn't really do anything, did it? Hmm, fine. Yeah, so the sensor test you can do like maybe once a day. It's not something that you will have to do before every single use. It's simply to try and calibrate the system so you ensure that all your readings are very accurate. And as you saw in the video, it's very short. So it's a couple of seconds. You put the test sensor in and that's all. Okay. So you may ask yourself, but why do I need OccluSense? I've got my papers, I've got my foils. It's working very well for me. I don't see the benefit of using OccluSense. I want to try and compare both the occlusion testing methods by showing you this diagram. So if we start with the current standard, which is occlusion control with papers and foils, then you can see that within this pathway, to get from checkpoint 1, which is the very initial contact, through the very initial contact on antagonizing teeth, via checkpoint 2, so the pathway between initial contact and maximal intercuspal position, which is checkpoint 3, you would have to continuously monitor this process from point 1 up until point 3 to really understand what's happening in a three-dimensional process. So what we need to remember, even static occlusion, so something that we think is maybe just a moment in time, is something that proceeds over a period of time. So with papers and foils, we have the opportunity to look at this process only at checkpoint 3. So it's the last point at one moment in time. And this can be related to a snapshot, like a picture of one moment in time. This is not a video recording, not something that can give you an overview of a moment over a given period of time. OccluSense, however, I've spoiled it already. With OccluSense, you have the opportunity to look into this process at any given moment in time and over a period of time. So you can look at occlusion as a whole, and you know that this doesn't just consist of the final jaw position, of the final teeth position, but also the entire movement before this final intercuspal position. And according to this, you have the opportunity to take a video rather than look at a single snapshot at one single moment. But do you really need this much in-depth detail for every single treatment? If we take an implant as an example, we know that the threshold for tactile sensitivity, so for the patient to really feel anything, of an implanted construction is about 8 times higher than that of a normal tooth, a vital tooth, within its natural periodont. So any occlusal interferences, as for example, a construction that is too high, a construction that is too low, it will not represent or not present itself with the same symptoms as it would on vital teeth. So any disbalances within the system will be directly transferred to the entire craniomandibular system and may cause dysfunction. There may be plenty of other indications whereby an OccluSense can aid in much better and more precise diagnosis. So you have the opportunity to detect hidden contacts and interference contacts very quickly. So you just look at the diagram and you can see what is being my annoyance. You have the opportunity to detect combined periodontal damage early. If, for example, there's incorrect loading on your teeth, or on your patient's teeth rather, and you can look at the force distribution of the entire dental arch, as well as avoid chipping by avoiding improper loading, and record dynamic occlusion as well as static occlusion. And you can compare these recordings over time. I will show you how to do that later. Orthodontic changes can be recorded as well as any occlusion movements. And what you're also automatically doing, you are documenting and using it for patient education. So the concept of occlusion for people who have not learned anything dental is quite hard because they don't have anything to visualize. You can only tell them, oh, you know, over there, there's a contact, and they don't understand this concept. But if you can show them the force distribution in an optical way, so they have the opportunity to look at it on the iPad, it helps a lot. Just like any other CRM system, if you want to get started, you need to add a patient to your database, so you can then add any sort of data to that patient. You fill in the blanks with all the details, so name, last name, gender, and so on. The patient's number, you are able to select freely. So this patient number can be identical to the CRM system's patient number that you use within your dental practice. And to get recording, you select the patient, you can set them active, or you can load any previous recording in the list below. And once the patient is set active, you have the opportunity to start a new recording. You then adjust the time and the frequency of the recording, which you can also do directly via the handheld, so it doesn't really have to be done via the app. And then you're ready to start. So you place the handheld in your patient's mouth and instruct them to conduct any movement that you would like to have recorded. The data will then be automatically transferred to the iPad, and that's what it would look like. So the colored marks, as mentioned, will still be left in the patient's mouth, and you can make any decisions to adjust your patient's occlusion accordingly. What you should also be aware of is that once you press start on the iPad, let's say you selected 10 seconds previously, the 10 seconds won't start immediately. So there's no need for you to press start and very quickly rush, put your gloves on and go into your patient and tell them to quickly open your mouth. That's not necessary. So the sensor will actually detect the first pressure change and will then start the 10 seconds that you've previously set. So pressure 10 seconds, put your gloves on, go to your patient, and then very, very easily ask them to conduct any movement whereby the 10 seconds will then start once the first pressure change on the sensor is put on the sensor by the patient's teeth. Obviously, we've had some very intelligent people draw up not only a manual, which is available free for download on the OccluSense website, but we also have very easy to understand short videos for every single step that you're unsure about on the website. As you saw in the previous example, the iPad recording, it consists of data sets with different columns and colors. So I just want to talk to you about what these actually mean. What the colors tell you is more about the pressure that is being applied and the size of the contact points. So low columns, low pressure, high columns, high pressure. What green points tell you is we have an area of contact on a wider surface. Orange displays something in between green and red represents a very punctual contact. Let me try explain this further by giving you a diagram of a unrealistic bridge, as you can see here. So if you look at the load of this bridge that is being transferred onto the two pillars holding it, then you can see that the left pillar has a much wider surface to the ground. So this is characterized by green columns. The right pillar has a punctual single contact surface to the ground, which is why this is characterized as red. And the height of the columns display the difference in pressure change. What you always have to remember is that the OccluSense reading, it gives you a relative reading. So it's not something absolute. And what I mean by relative is that the pixels that are being activated on your pressure sensor are always being compared to their neighbors. So in the right column, where you can see the red pressure change, we have one pixel being activated within its neighborhood, and that's why this single pixel is red. On the other side, because there's different pixels next to each other in their neighborhood being activated in a similar manner, we have a wider contact surface to the ground. So this is why this is green. That's what you have to remember. Relative reading compared to people in their neighborhood. Another bridge to try and bring this example a bit closer to you. So you can see a small pressure change between the green columns, an intermediate pressure change at orange, and the highest pressure change that is punctual for red. How do we transfer this knowledge now onto the three-dimensional movement during mastication, which is very complex? If you try and visualize yourself standing on a plate covered with needles, and each of those needles, they obtain a different amount of pressure from the weight that is being put on it. What do you feel? So apart from the pain, we're now taking a little cutout of that needle plate onto here. And please remember, we are always comparing all the neighborhood needles to one another. In relation to one another, you can see that on the left-hand side, we have two needles with a very large pressure change relatively to the others. And that's why these are red, because the pressure change between those two needles is higher than the pressure change between the needles on the other sides of the plate. Then you have orange and yellow in between, and green as the lowest pressure change. Therefore, red columns indicate high spots of contacts. They indicate initial contacts and standalone contacts, always in comparison to their neighbors. Whilst green indicates a very low pressure difference between the pixels that are being activated. So this means we have planar contacts, as for example, on abrasive teeth, where we have wider surfaces being activated, or adjacent contacts with similar pressure. You need to remember that red in this case is simply a color. It does not mean alert, you need to do something, but it's just a color that is being used to show you that in this area we have standalone contacts and high pressure changes. And as mentioned previously, we have a neighborhood, and that neighborhood is being compared to one another. Let's try and look at this little cutout of an example for an OccluSense reading for static occlusion. I want you to try and analyze this, and if you're looking at all the different colors, that you can see that in the right molar region at the back, you don't see any red columns. But this does not mean that you don't have any high pressure here. In fact, if you look at the pressure distribution, which is noted by the percentages around the scalings, then you can see that actually the highest pressure within the entire dental arch is located right there. So 23 and 21% is nearly 50% of the entire pressure is right there, but we don't have any red columns. So what this tells you is that we don't have any standalone contacts with high pressure changes compared to their neighboring pixels, but the contact surfaces are rather planar, and the pressure distribution within this dental arch shows that we have a lot of pressure here actually, despite there not being a lot of red columns. And the same level of detail you are able to detect for dynamic occlusal readings, lateral occlusion to the left and to the right. I'm also going to take you through some of the features that I personally find helpful. So you're able to amend your viewing options from 2-dimensional to 3-dimensional, or my personal favorite, the joint option, where you see 2D and 3D in one overview. Just because this combined view, it shows you what is my pressure distribution in a quadrant distributed sense, and how high are my columns. Obviously, you are able to switch between full screen and go into a smaller screen. You can use your finger to turn and rewind your the dental arch. You can pause, speed, rewind, do some noise cancelling. So this means I don't want 256 pressure levels. I don't need that much. I want less. So you can toggle the bar and then amend the amount of pressure changes that are being shown to you. And you are able to compare two recordings by selecting them and then going on to compare two recordings. This is just to show you the noise cancelling tool a bit, and the filters that you are able to use. What you can also do is export the data from the iPad by entering the full screen mode. So you have to tap the full screen button. And once you've done that, the export button appears. And then you can export your file either via PNG, and that will be saved onto your camera roll, or to PDF, which will then be exported onto your files, including any comments that you can enter for every recording. The same you can do for any video. And remember to go into full screen mode, and then you can screen record and toggle your page. So do whatever changes you want to do with your finger. If your mic is also activated, you can speak any comments that you want onto this recording. And once you're finished, you press stop and export your file onto your Photos app. You can also use the app files from Apple to export the recordings to any external drives or to your network. Please take a look into our network access guide for this, which is supplied with every OccluSense and which you can find on our website. Okay, so we can finally get a bit more clinical. In order to trace back your columns and your color changes on the OccluSense reading back to your patient's mouth, you need to try and retrace your steps. So what you have to do is You have to ensure that your midline in the patient's mouth is also the midline in the sensor. So you can see that every sensor has a red marking. So it's either a little triangle, sometimes you have a little line. So you have a marking for your midline, and this midline marking you insert into your patient's midline, and then you can one-to-one trace back every single column to the patient's marking on their teeth. The segments can try and make this a bit more specific for you as well. If we look at this example, then you can see that the blue circle indicates a 2-point regular molar contact. So take a look at the clinical view, take a look at the 2-dimensional and the 3-dimensional view to see how these pop up on your OccluSense reading. If you then look at the orange circle, then you can see a very regular contact on a premolar. And shown in purple, now I also want you to look at the clinical view, not only the OccluSense reading. Then you can see that on the very, very right, you have the 3-dimensional view. So you see that there's actually very high pressure distribution here, as well as in the middle reading, where you can see the percentages in pressure distribution. And I've also circled for you the percentages, because you see that there's 50% of the entire pressure change being detected in that quadrant. Why is that? So it means our occlusion is not evenly distributed. And if you then look at our clinical view, that you can see that tooth 36 actually has a buccal contact, which is something that is not normal. So now we know that we have a premature contact that is causing this unevenly distributed pressure distribution. And the same you can obviously do for dynamic occlusion. You can see here a non-balanced group guidance, with most of the pressure being located in the bottom right quartile, and a very single contralateral contact on the antagonizing movement. And if you imagine that tooth 36 was an implant that we had placed, which long and short-term consequences do you think that this improper loading will have on the survival rate of our implant? The same can be done for protrusion, and you can again see improper loading on the antagonizing movement. I'm gonna start with the first clinical case that is very nicely being provided by some of our clinical experts all over the world that are using OccluSense for us. And the first case is a patient with bruxism. So this female patient, she presented herself with ringing in the ear. She felt that there was absorbent cotton in her ear, cervical spine and ligament sheath prolapse were diagnosed. She also had a problem with a thyroid gland and muscle tension in her face between nose and ear. If you look at our static occlusion with OccluSense, then you can see a primary pre-contact on 48, some unequal loading, and final heavy load between 41 and 45. Looking at a protrusion showed again parafunctional contact on 48. And the parafunctional contact on 48 it prevailed for medial occlusion to the left without any canine guidance. And on the right side, we have no group guidance. We have group guidance, I'm sorry, but no canine guidance. And our parafunctional contact between 48 and 38, it still remained. Her bruxism movements went over 43, but again, with parafunctionality on 48. When we looked at her nocturnal movements overnight using the OccluSense spray, we detected that there was in intercuspal position, in centric position, there was a prevailing contact on 48, and very, very small fabrication of this contact actually led to her losing all the symptoms that she presented herself with right at the beginning. You don't necessarily need an anamnestic I don't want to say disease, but something that's causing any symptoms. So you don't need any symptoms to use OccluSense to look at your patient's occlusion. You can also merely record their occlusion to compare them over a period of time or to ensure that their pressure distribution is evenly. And for this patient, you can see that in this entire dental arch, you have a very evenly distributed pressure. Please don't be alerted by the right back molar region. It's because there's no antagonizing teeth in the fourth quadrant, which is why we can't detect any pressure changes there. But the occlusion is very evenly distributed, as you can see in her static occlusion. And the lateral protrusion to the left also showed a very healthy canine guidance, with the markings also being left on the patient's teeth. So you can see the pathway nicely being put on there. And a protrusion. The final clinical case I've brought for you today is OccluSense and splint therapy, very much more becoming popular topic. And if you look at the panoramic overview of this patient, you can see that the condylar processes on the left and on the right side are very differently shaped and formed. So we actually have a case of hemimandibular hyperplasia over here. And according to the differing development of the condyles of this patient, she suffers from CMD, whereby any occlusal differences that she has also lead to teeth grinding, especially at night and during stressful periods. And since this patient was actually over 30 years old, she chose no surgical intervention. And therefore, our primary treatment involves the preservative symptom management, whereby we fitted a night guard to protect her teeth and the joints. If you look at her static occlusion without a night guard fitted, you can see that she actually has an open bite on one side. So once the recording starts, I think this is much more easily to see. And I want you to look at particularly the occlusal interferences and disbalances, as well as the force distribution. So let's look at this again. So right at the beginning, her first occlusal contacts. Only on the right-hand side she has any contact. So to begin with, we have a open bite on this side and occlusal contacts on this side. And due to sliding and gliding, then further contacts slide into place. However, we can see very clearly that this is not a evenly distributed occlusion. And this is an occlusion with the night guard fitted. And I want to ask you, so if you are putting a splint or testing a splint in your patient's mouth, what do you do? What we do is we use shim stock foil and we use a premolar wide tip strip rather, and we put that premolar white strip into the patient's mouth and test everywhere where we want to see a contact. So we start in the, for example, left molar region, and then we are looking for 2 molar contacts. Then we go onto the premolar contacts. Again, we're looking for 2. We check the frontal or anterior teeth, and then we go on to the other side. And what we do is when we put in the shim stock foil, we try and pull it out again. And if we feel some sort of resistance, we say, all right, we have a contact here. And you do that all over the entire dental arch. But you have to think about the objectivity of this method. So for every time you're pulling out, number one, you don't pull out in the same force. Number 2, you don't feel the same resistance each time. So it's something you do by feeling. And I mean, for dental professionals, this is something you've done your entire life. And I mean, it does work, but it's a bit time consuming to try and use the resistance that you've used previously each time and make sure that the force that you're using to pull out is also the same. And it's actually naturally impossible to do that. Um, so for this patient, when we tested the splint, we used shim stock foil very simply. And when you're looking at the beginning of this OccluSense reading, because what actually happened was when we tested the occlusion of this patient with shim stock foil, it was quite evenly distributed everywhere. And if you remember the pathways that I showed you, pathway 3 that you're using with simple foils and papers, it shows you number 3, so the final position. And if you look at this OccluSense reading, then you can see the final position. So imagine you're pulling out here, you're pulling out here, you're pulling the shim stock foil out here, you get a resistance that's quite similar everywhere. And this patient, for her checkup appointment, she actually said that she still had some pain. It was very unused, so she wasn't used to this kind of movement, which is why we then looked at her occlusion with OccluSense. And this is what you can see, this final position right at the end is what you can see with shim stock foil. And as mentioned, this is roughly the same resistance everywhere. But if you look at right at the beginning of this reading, you can see that there's an uneven distribution. So we have nearly 90% of the entire pressure right at the start in the anterior left. And this goes further, slides, slides, until we reach some point here, where we have roughly the same pressure, meaning that the shim stock foil will hold everywhere there. And exactly the same you can do with dynamic occlusion. So looking into her canine guidance, the splint definitely needed to be fabricated a bit more to give you a evenly frontal and canine guidance. And moving on to protrusion to finalize the process. And maybe the most relevant question for you now, does OccluSense replace my articulating paper? Can I throw all my papers out and just get an OccluSense? Yeah, it really depends on the indication. I wouldn't do that if I were you. I find that OccluSense is an extremely helpful diagnostic tool for good clinical decision making, and it speeds up a lot of processes. And it really, really depends what kind of treatment you're doing. So with papers and foil, you have the opportunity to take a quick snapshot of one single moment in time. However, OccluSense gives you the opportunity to look at this process over a period of time. So you have a video recording rather than just a picture. And what I personally do is the following. So this algorithm, I can really suggest you can use OccluSense to check for premature contacts and give you a very, very quick overview. and also give you an overview of the pressure distribution. You can do any fine adjustment by using your papers and your foils, and then check and control your final treatment with OccluSense again. And what you're also doing automatically is you're documenting this entire movement. And we have testimonials of experts all over the world specializing in various subjects. Some people use OccluSense for very normal conservative dental procedures. We have experts using, as spoiled before, OccluSense for CMD. So this is a topic that is becoming a lot more popular, but also implant prosthetics. So you can see plenty of experts, not only from Germany, but also Brazil, Turkey, France, and so on. And if you're as convinced as me, to get started, you will need an Apple iPad, and supported versions are produced in 2014 and later. You need the Apple iPad Store. Um, the Apple iPad app, sorry, which can be downloaded from the App Store. And it's free to download. All the updates are free, and it's supported in 12 different languages. You need a Wi-Fi connection, which most of the dental practices will have anyway. And you need the OccluSense system BK5000, which will provide you a loading docking station sensor to start with, a instructions for manual use if you need to change any batteries. I say today, thank you so much for your attention. If you have any for me today, I'm very happy to either read them in the chat or turn on your mic and speak to me. I can also already see a question, which I will read out. I'm going to start with the question in the chat. So if I'm doing full mouth reconstruction, I should focus on the percentage of load distribution rather than color of the columns. Is that right? I would agree to that, yes. So start with your, for the full mouth reconstruction, definitely start with the percentages because they give you an indication of where the pressure is located and if it's evenly distributed, because that is, in my opinion, your aim. So you want to have an evenly distributed occlusion. And if you want to look at the wideness of the pressure and the type of contacts that you have, you can also look at the color of your columns. I hope that answers the question. Another question, does the device allow measure occlusion time and disocclusion time? Absolutely. So what you can do is look at your OccluSense reading. It gives you the seconds that you have for any movement. And you can also instruct your patient and practice it with them beforehand. And then you can measure from the first occlusal contact on your OccluSense reading onto the last occlusal contact to give you occlusion time and disocclusion time.
I'm in the meeting. I'll get back to you. I'm in the meeting.
Any more questions? We don't have the opportunity to quantify the forces, so it's always relative measures. I mean, if you think about it, what kind of what consequence would the actual force have for your treatment therapy? it's only necessary to know relatively how high the force is. The next question, if I'm going to assess and compare occlusion before and after prosthodontic treatment, sorry, how should I go? I've shown in one of the slides the opportunity to compare your occlusion before and after. So obviously you need to name them appropriately. So name them as static occlusion every time you are saving your data, and name your lateral protrusion to the left as one, to the right as one. And then if you then compare your recordings, you can look at them at the same time next to each other and then compare your prosthodontic changes over time. Sensor accuracy validation studies. There have been some clinical studies on OccluSense, also comparing other digital occlusion methods. If you go into PubMed and you pop in OccluSense, you are able to definitely look at a few studies to see at the accuracy. Okay. So I'm going to give the chat another couple of minutes. As said, feel free to note down my email address and connect via LinkedIn. If you have any cases you want to discuss in the future or questions that you can't think of today, but you think of them when you're using OccluSense, please feel free to pop them by email or LinkedIn to me. Only an iPad is actually compatible with OccluSense, so there's no other devices that you can use. Another question regarding OccluSense to equilibrate prosthesis. Absolutely, you can use it right from the start. You don't need to use it to verify because it gives you an overview of your pressure distribution, and you definitely need this to initiate and equilibrate your prosthetic treatment. So it's not just for verification, it's also to give you an overview right at the beginning. Okay. It seems that there are no more open questions. If that is the case, then I want to thank you very much for your attention again. I'm wishing everyone a very nice Saturday. Today we have a carnival in Cologne, so we all have to put on some costumes and go on the streets. If you've never been to Cologne, then the carnival time is a very interesting and good time for you to join. And yes, I look forward to maybe hearing some cases in the future if you want to share them with me. As said, note down my email address. Thank you very much for your time and have a lovely weekend. Goodbye.